Hello, everyone, and welcome to our webinar on building a person-centered plan around a meaningful long-term goal statement. My name is Mark Grimaldi, and I'm a Human Service Program Manager at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. And thank you for joining us today to explore the ways that we can build a PCP that is centered around a long-term goal statement. And at this time, I'd like to pass it over to Dr. Janis Tondora with the Yale Program for Recovery and Community Health.
Excellent. Thank you so much, Mark, for the intro and your support of this initiative. So let me just start with some quick housekeeping, then I'll do a bit more of an introduction. So first and foremost, people are always very eager to know how you get your certificates of completion in terms of CEUs. So I just want to direct your attention to the screen here. When you get the slides, there is a hyperlink in the top right there to a document that has more detail on this. But in brief, you have to be with us today for the full duration of the event in order to get your NBCC credits that are associated with the webinar. You need to be logged in through your unique registration link, which is attached to the email address. If by chance you happen to have registered as an individual, but you have a group of folks sitting around one computer right now, we will not be able to issue a certificate except to the one person who logged in and registered. So if you've done that, it's really important that you take the initiative to reach out to us, to my colleague Ingrid Paget, and to let us know if there were others attending alongside you. Okay, you're also required to complete a very brief post-event training evaluation survey that's required for your NBCC cert. And also we do, in fact, use that information in a meaningful way to continuously improve these events. And please just kind of, keep an eye out on your email because you'll get some follow-up communications. That survey needs to be done. Hopefully you'll do it at the end when we give you a QR code and a link. It's super quick and easy, but you only get 2 weeks before it closes because we have large numbers to process. And then give us about a month before you reach out to Ingrid and inquire as to where your certification might be. Sometimes it goes into spam folders. So if it's not there within a month, check your spam and then reach out to Ingrid and we'll do what we can to sort it out for you, okay? Other things from a housekeeping perspective, we have a very large group today. So we mute audio just to kind of reduce the interference. If you have technical issues, please direct those in the chat to my colleague Ingrid Paget. Even though we're a big webinar with a lot of people, a lot of territory to cover, I try to build in a lot of interactives. And so you're going to be using your chat box and doing some polls. So please be ready to do that. And as I mentioned earlier, you will get a copy of the slides as well as a recording of today's event, usually within a few days to a week after the event. So we will save some time at the end, have a little bit of time at the end for questions. You're also welcome, and I encourage you to put questions or comments or your own ideas into the chat box. I only ask that if you do that, please don't direct them exclusively to me, because as I'm facilitating exercises and content, I might miss something important. So please direct those to everybody so that, again, we can kind of help each other at the end, circle back to questions if I haven't answered them. Okay, so let me just tell you a little bit more about me and who I am and what I do and what we're going to cover here today. For those of you that don't know me, my name is Janis Tondora. I use she, her, hers pronouns. And for anyone with visual disabilities for accessibility purposes, I am a white woman with long light brown blonde hair. And I'm wearing reading glasses today, sitting in front of a beautiful virtual background of my hometown of Milford, Connecticut, along the shoreline. And I am a clinical psychologist by training. I have been doing this kind of work in person-centered care and planning for over 25 years, first in broader disability populations. In particular, really looking at designing inclusive education classroom supports to maximize inclusion of kids with disabilities in regular education settings. And then I shifted on over, and more of my recent work has been in adult behavioral health, where I am currently an associate professor at the Department of Psychiatry at a place called the Yale Program for Recovery and Community Health. And I do this kind of work with different stakeholder groups, people with lived experience, providers, leaders, administrators, funders. In my home state of Connecticut, lots of states around the country, I do quite a bit of work with the feds, whether that's Centers for Medicare and Medicaid Services, the Department of Justice, SAMHSA, et cetera. And I'm really just very passionate both about teaching, but also learning from all the groups that I meet with. So I'm looking forward to today's conversation. And I also bring a personal lived experience to this topic, because I first got turned on to person-centered planning over 30 years ago, when it literally, I would say, saved the life of a family member who had experienced a traumatic brain injury and helped him rebuild his life bit by bit when he was finally able to access a person-centered planning waiver. So I'm going to try to bring that mix of personal and professional background and experience and offer you a whole bunch of tips and tools around our topic of the day, which continues to be a very hot topic. We're going to dive in detail. But first, that was a little bit about me, but it helps me to have a sense of who you all are. So I'm going to ask Ingrid to open an audience poll. And multiple hats are allowed, because you may occupy more than one of these stakeholder roles, but it will give me a sense of who's with us today and what kinds of questions you might be bringing to the event. All right, Ingrid, I'm going to say, why don't you go ahead and close that? We've got a majority, and share our results here. I also want to be checking out chat, because we have quite a few folks who said other in the chat, which is great. And I want to know who that is. But as is often the case in this webinar series, we've got a great diversity across our different stakeholder groups. So direct support practitioners who might be facilitating person-centered planning, folks in leadership positions, people with lived experience personally as family members. Thrilled as always to see people from administrative positions and leadership. We often talk about this practice of person-centered planning. In order for it to happen at a micro level, in terms of service delivery and supporting a person or a family, we have to align at the systems level around everything from quality monitoring to how we finance services, mission statements, you name it. So it's great to have you here. All right, I want to check chat, because we have quite a few folks who had said other. So we have some community health worker, it looks like. That's great. Some qualified practitioners, some of our TCM care managers, representation from foster care. All right, excellent. Okay, great. Thank you again for doing that. And let me move on. Just so this is a brief historical timeline of the history of the PCP initiative in North Carolina, because it really does date all the way back to the 90s with the Thomas S. Class lawsuit that was underway. It's included everything from the development of an original PCP manual, ongoing training. There was the nice addition and expansion of the behavioral health recovery-oriented care movement. Ultimately, all of those efforts informed an updating of a new stakeholder-driven PCP guidance document that came out a few years ago. And again, ongoing training and quality reviews. So mostly this slide is really intended just to give nod to the fact that even though I've actually only been in the scene for about 3 years doing trainings and webinars, there's a long-standing history of efforts in these areas. And there's been some good progress that has been made, but also the ongoing quality reviews indicate that there's still some space for us to keep moving in the right direction, particularly as it relates to how we reflect good person-centered planning work and good person-centered planning documentation. And then at the end there, what you will see is that a particular piece that we were excited about, we've had a lot of these initial introductory trainings, we've had these hot topic webinars, but last year we also developed a really comprehensive person-centered planning resources toolkit that is housed on the BHS Behavioral Health Springboard website that is packed full of resources, including an entire section of materials that are on goal setting and vision planning, which is really kind of the topic of today's conversation. So I'll tell you a little bit more about that in a second here, but the key thing I want everyone to know is that this website resource does exist, and the way that you access it, you are required to take the introductory training. So without further ado, I'm going to have Ingrid open our second poll. So we had this standard introductory person-centered planning training back in 2022 and 23. I did that 6 or 7 times. It was a 4-hour live webinar. Some of you may have participated in that, or some of you may have taken the BHS archived version, but either way, let us know if you've taken that training, because it'll give us a sense of kind of, again, knowledge that you're coming in with. All right, Ingrid, you can go ahead and close that. All right. Okay, great. Every time that we do this, this is going up, which is what we like to see. At last check, I think we had pretty good penetration around this date. I think we are getting up close to around 11,000 people or so had taken that. And we've got 60% of you with us today who have taken that. So again, this is building off of knowledge that you already have, but hopefully giving you some new tips and tools in a particularly hot topic area around which there's quite a bit of confusion around the documentation of those PCP goal statements. So in terms of the PCP resource toolkit, for all of you who have already taken that introductory required training, you have access to this. Again, these are sort of screenshots of what it looks like. And we worked, gosh, for almost a year with a team of stakeholders across all different roles, practitioners, people with lived experience inside of North Carolina, around the country. And we really did the hard work for you to curate some great resources, including this entire section that's devoted to goal and vision setting. So if you are looking for tools to support this process of identifying those long-term goals and setting the vision, please check out that toolkit. It's a great resource, and so far it's been pretty underutilized, so we're really trying to make sure that people have awareness of it. Okay. All right, here's a little opening exercise. So we're going to go ahead and get going, and I'm going to get you all active, and this is going to require you using your chat box, okay? So the first question that I want to ask all of you is, I'm giving you permission to take off your person-centered hat. Take off your recovery-oriented hat for a minute and think about traditional treatment systems. Think about how we traditionally define outcomes. How do we traditionally define improvement? What are the things that we measure traditionally in traditional treatment plans? and start putting some things in the chat box for me. I will get us going because I do hundreds of chart reviews. Or let me see if it's coming to the chat already. Yeah, medication compliance, Lisa, probably number one, still in the hundreds of charts that I review. So think about, again, traditional treatment planning. What do we typically focus on? Staying out of the hospital, right, Kaneko, staying out of jail, personal hygiene, all of the ADLs, attending services, med management, abstinence, diagnosis, okay? Attending and showing up at groups. Great, keep them coming. Yeah, regular doctor's visits. Great, let me see if I'm missing anything else in here. Good, good, good. Okay. All right. How about, Ingrid, I'm getting Dolores, right? I apologize. Oh, family. I see you're trying to spell something, Dolores. I thought that that was me and I was clearing the scribbles. So yes, more so in recent years, we have been focusing on inclusion of family and natural supporters. But I would really argue in traditional treatment planning, we've been pretty heavily focused on those things that people just put into the chat, okay? All right, so second question for you all is this. Now, I don't want you to think about yourself as a professional. I want you to think about yourself as a person, as a human being. And what I want you to write down in the chat box is I want you to write into the chat box 3 things that give your life meaning, that put a smile on your face, that get you out of bed in the morning, that give you a sense of purpose, however you think about it. The 3 most important things in your life personally as a human being, and to put them in the chat. I know it's hard to pick 3, but try to pick 3. Family, faith, friends, my spiritual connections, my partner, my husband, my health, paid time off. Maybe we're traveling. Maybe we're doing other things. I see faith coming up on the screen there. Being a good mom or a grandma, having friends, payday, going out, maybe having some fun, having a sense of financial security. Participating in the arts, maybe gardening. I'm with you. Another Janis out there who loves gardening. Music, my children, whatever it might be. Family, hope the Lord, my purpose. Helping others, giving back, okay? All right, that's terrific. So now here's what I want you to observe. Hold on a second here. When I asked you to think about what do we traditionally focus on in traditional treatment planning for people with disabilities, what do we focus on as outcomes? What do we measure? What does the treatment plan get filled up with? We got a list that looked a lot like the list on the left. But then when I asked you to use your own personal frame of reference as a human being personally, what gives your life meaning, we got a list that looked a lot more like the list on the right. And I would argue that these 2 lists are very different, okay? So just put some observations into the chat, anyone who can. What do you notice about these 2 lists and how they're different? Put those into the chat for me. The left versus the right, what do you notice? Yeah, the one on the left is very clinically narrow and it doesn't speak to the person. The right one's more personalized. The left one is all about treatment and the right one's all about our life and what matters most to us. And what we hope for others, again, is like limited, very narrow to like the clinical management of symptoms. It's about surviving on the left. And on the right, it's more about thriving. Someone mentioned into the chat that the right side is just easier to understand. It sort of speaks to our heart emotionally, and even in terms of the language, we can just connect to it a little easier. And Anjoli is picking up on again, the left side is what we hope for them, but the right side is what we really value for us personally as human beings, okay? So the key piece in this opening exercise to get you thinking before we dive into some of the coaching is that people don't just want to survive an illness or a disability. They want to thrive, and they want the exact same things out of life that everyone else does, whether they live with a label or a diagnosis or a disability or not, okay? So the beauty in this model, we are not saying that those things on the left-hand side are all bad or that they don't belong in a person-centered plan, okay? What we're saying is the plan cannot be dominated by all that stuff on the left to the exclusion of the things on the right. So we have to figure out how to do an integration, okay? So for those of you who are like getting nervous, or you go in the world of medical necessity and interfacing with your funders and clinical justification for care, some comments are coming in that, you know, the one on the left is maybe more measurable, or it's more objective, or it's more rigorous, and that's what we need in our documentation. And sometimes I think people worry that the one on the right gets a little too loosey-goosey. So we're going to talk about this a lot. I'm going to demonstrate it. But please rest assured that I am very cognizant of and do a lot of work with people around this idea of how do we first and foremost write a plan that honors the person and make sure we're focusing on what's important to them, like the things on the right. But also, I very much understand that you have tremendous pressures around weaving that golden thread of medical necessity and tremendous pressures around the technical rigor that is required in your documentation. I wouldn't be doing this work if I wasn't the optimist that I really, really felt like we can integrate those things in one good quality, well-documented plan. So I promise we're going to get there, okay? All right, and Gladys, we'll talk about folks who are struggling, maybe families not involved, they're having a hard time setting goals. We're gonna get there, we're gonna come back to that question, okay? But my last question for you on this opening exercise is, for those of you that put the 3 things in the chat box about what gives your life meaning, I want you to imagine just for a moment that Janis Tondora is crossing off the middle thing from that list. I'm just crossing it off and telling you, not right now, not ever maybe, but imagine what your life would be like without that thing in it. And just put some words into the chat box. What would that feel like for you to have me cross something off your list? Depressing, empty, sad, lost, frustrating, powerless, invalidating, heartbreaking, lonely, crappy, rude, not heard, totally lost, hopeless. You know what? How I would feel? I would feel pretty angry. I know I would feel pretty angry, okay? All right, so here's what I want you to think about. First of all, let me be very clear. I don't believe that anyone goes into this business of supporting people with disabilities to cross anything off their list. I think we have good hearts, we have good intentions. But sometimes the way we're trained or the way that our systems are structured, we end up in that sticky place where it ends up happening inadvertently, okay? So just to give you an example, if I'm sitting in a treatment planning meeting, a person-centered planning meeting, co-facilitating that meeting, and a person says a half a dozen times more than anything, all they want to do is get back to work and get a little part-time job and be a good provider for their kids. And if a practitioner in the room says, we know that's important to you, but first you have to do 90 meetings in 90 days and have 90 days of clean talk screens before I'm going to refer you to supported deployment. So in that moment, in that interaction, a focus on abstinence and attending services gets put on the plan. and the employment gets crossed off, okay? Or same thing, people who maybe have lived in state hospitals or institutions or group homes, adult care homes, more than anything, they want a key to their own apartment, right? They've been waiting for 40 years. And they hear things in treatment planning meetings still, like, we know that's important to you and we'll get there eventually, but first you have to show us 6 months of med compliance, and then we'll talk about the transition to the supported employment. So in that moment, what the person experiences is med compliance gets put on the plan and a home of their own gets crossed off, okay? And again, there's lots of reasons that these things happen, and very often it's not about the good hearts or the intent of the individual practitioner, but I think it's important to kind of start in this place with this exercise, and to sort of put ourselves in the shoes of what this would kind of feel like. Because at the end of the day, as I was saying, folks want the exact same thing out of life as anybody else, whether they have a disability, an illness, you name it. And all of that really starts with and flows from a quality, valued, long-term goal statement, which is why we have decided to repeat this webinar, because it's such a critical quality part overall of the PCP, okay? All right, I'm gonna ask a technical question. I'm getting all sorts of doodles coming in on my screen, like annotations, and I thought it was me, and I keep having to clear them, and sometimes y'all are trying to respond to exercises that I'm doing, but I'm going to ask if you can please use the chat box, because I'm getting a little frazzled trying to clear some of the annotations, or if you need tech support, if there's an accessibility or an accommodation need, if you could please message Ingrid in the chat, that'll really help me out, okay? All right. So again, I mentioned this is essentially a repeat of a Packed House webinar that we did back in January, because it is, in fact, a very hot topic. And there has been quite a bit of progress made in the state of North Carolina around PCP as it relates to some of the Department of Justice expectations and the Olmstead Settlement Agreement. There's been great stuff happening in recovery-based services, in some of the peer-led organizations, in some of the community inclusion programs that are active around the state. But there's also been some persistent struggles in some places where the annual scores and the quality monitoring continues to really lag. So they're still seeing quite a bit of sort of kind of cut and paste, sort of copied generic goals. And they're having a hard time sort of seeing a person's individualized voice show up within the documentation, okay? North Carolina is not alone in this struggle. I mentioned I've done this work in, I think, almost 30 states at this point. And a lot of times what is happening is there can be beautiful person-centered work being done in practice, but when we try to make the leap from that practice and that relationship into the actual documentation, sometimes the quality really falls off and the good work is not showing up in the plan documentation. So if you fall into that category, hopefully you'll see today's webinar as an opportunity to really get credit for the good work that's already happening, okay? Because again, whether it's in North Carolina or around the country, CMS does a lot of, they call them heightened scrutiny site visits and programs that are required to do PCP, like the Home and Community-Based Services Program. And they're finding similar struggles in the sense that the quality of the plans still really isn't there. And it's important, again, to continue to access new tools and tips so that we can kind of continue in this ongoing improvement process, okay? So here's a big picture snapshot of the logic model that we have been coaching across the years in the PCP initiative. This is how it's laid out in the North Carolina PCP guidance document. Okay, so you may notice a couple of differences here. A lot of traditional treatment plans get organized around the problem list, right? And for every problem that pops hot in the assessment, then we have a goal and treatment plan. This is much more so a goal-directed method of planning, with the goal really being defined by the person. What do they want to be moving toward in building a good life in the community? What strengths do they have to draw upon? And then what barriers or assessed needs or problems, you may use different terminology to describe those things, but what things that are associated with a person's health condition, their mental illness, their disability, substance use concerns, what things are getting in the way of their long-term vision of their life. Then we drill it down into what's going to be the first concrete step, the proof that we know we're going in the right direction. That's the short-term goal statement. And then finally, how does the whole team work together to help the person get there, okay? And that team is expanded in the person-centered world, and it includes not just all the professional cast of characters, but a much more active role for the service recipient, as well as any natural supporters that they bring into the loop, okay? So the focus of today's webinar really is very heavily on that top box. And then how do you kind of weave that through down to the short-term goal or SMART objective? I saw a lot of comments already coming in like, but we have a lot of pressure about measurability. And I understand that. I understand that technical requirement. So I am going to at least touch on how you satisfy some of that through those rigorously documented short-term goals as objectives. Okay. So that's just a big picture view of where I want to start. Okay. For those of you that are using the recommended planning template that was proposed and offered to you all, again, recommended, not required, but this is a snapshot of the PCP template that was included within the guidance document. Okay, and big focus today is in that top box. But again, I'll try to at least kind of get us through objectives and maybe even end with a quick snapshot of how it comes together in a full plan. Right? I'm just trying to orient you and ground you if you're using this particular template. All right, so when we talk about the long-term goal statement and organizing the whole plan around it, the big phrase that we often talk about is you want the goal to be something that is important to the individual you are supporting, not just something that we think might be important for them as professional providers, okay? Sometimes those things line up, and sometimes we have to take a step back and do a little more work to get there, okay? Because we can't really know what a person needs in terms of treatment and supports until we first understand what it is that they want out of life as a human being, right? What are their personally valued long-term goals in life? What are the things that matter most to them in their lives? And if we develop the treatment plan and the interventions in a vacuum from that, we're going to miss the boat a lot of times, okay? So I'm very transparent, and I often use my own story to illustrate this because I'm someone who is living with a very serious brain tumor. I'm living well, by the way, living quite well with it. But about a decade ago, I had to have a really major brain surgery, pretty dangerous. And there were a couple of ways that they could do that. And in option A, there was a very small chance that I might have cognitive or personality issues, but they were completely confident that they could protect my hearing and my balance, okay? And then in option B, there was no chance of cognitive or personality problems, but I was guaranteed to lose my hearing and my balance, maybe even some issues with my vision. And originally, my team of doctors was pushing me really heavy into option A because they really wanted to preserve my hearing, my balance, make sure my vision was okay. But at the end of the day, I said, y'all, you signed me up for B. Like there was no question in my mind that for me to be a good mom, a good friend, a good teacher, I could do that if I lost my hearing, my balance, my vision, but I wasn't willing to even take the tiniest chance that I would wake up from brain surgery and not be me, okay? So that was what was most important to me based on the roles in my life that I valued, right? Now, if I had been a professional, I can't hold a tune, but if I had been a professional opera singer or a pianist, preserving my hearing, it may have been really critical to me because maybe music is a huge part of my identity, but that wasn't the case, right? But you don't know that unless, as a treating professional, you take the time to get to know what matters most to the person, okay? And that is really the beauty of that long-term goal statement and finding out what's important to the person, okay? So I'm going to give you lots of examples of that as we go through, but let me just give you some tips and examples, because long-term goals in a person's life, what do they typically look like? I mean, typically people want to live, love, work, learn, play, and pursue their dreams in the community, just like everybody else. That's the language from the North Carolina PCP guidance document, by the way, at the bottom there. And folks want to finish school. They want to have control over their own money or their meds. They want to get out of an adult care home. Maybe they want to get invited to a birthday party at school or join the soccer team, okay? Those are what things that motivate people, things that are most important to them in their lives, and they go beyond the territory of traditional treatment plan goals. So traditional treatment plan goals will often look like this: decrease aggression, improve your hygiene, maintain your stability, take the meds, show up at group, follow the behavior plan, et cetera, et cetera. Again, it's not to say that there couldn't be some benefit to a person's life in reaching their goals if some of these things are in place, but this is not the end game. Nobody comes into treatment saying my goal in life is to be med compliant, okay? It has to be in the service of something larger that gives a person's life purpose and meaning, okay? So think about it from the perspective of engagement, really. And if you're a person who's struggling with some behavioral health issues, you may want to have friends and family back in your life. But if you got a copy of your treatment plan and it's saying improvements in interpersonal boundaries and socialization, communication, and relational skills, I mean, I don't know about you, but I'm not going to get very excited or maybe even understand what half that stuff on the right side means. But I know what it means, and I know what it means to me to have friends and family in my life. So we're really thinking about language and focus and focusing these things on what's most important to the person in their life. Sometimes it's helpful for us to contrast these things by what traditional treatment plan goals might look like and what good person-centered planning goals might look like. So on the left there, you can see, the more traditional type of goals, the patient's going to be med and treatment compliant. When really what they want out of life is they want to go to college. And maybe part of that is figuring out how they use medications effectively to be able to get up and go to class and focus. But the end game is not be med compliant. The end game is be successful in going back to college, right? Same thing if you work in the youth and child space. And I see a lot of plans still, Joe's going to stop throwing chairs around the classroom. He's not going to have behavioral outbursts. But have we really, what is it that Joe wants most? Yes, that's something that's problematic. It's going to need attention in the plan. But if those things can be better managed, what's that going to allow Joe to do? Is going to be able to go on the field trip with his friends? Is he going to get invited to classmates' birthday parties because he's feeling left out? Okay. So again, just trying to give you some examples of how it comes together in the actual documentation. Okay. All right. Again, feel free. I'm doing the best I can to keep an eye on chat and respond to observations. If I don't respond to your observation or question that comes into chat, it's often because I know I'm going to get to that point in about 2 or 3 slides. So be patient, and we'll try to also save some time at the end for some short Q&A. So just some reminders about goal setting in person-centered planning. Okay, so it can be pretty intimidating. I mean, just think yourself, if somebody asked you, like, so what are you, I have a rising senior in college, and a lot of people are saying, like, oh, so what are your goals? Where are you going next? It's pretty darn intimidating, right? And then if you add to that, if a person has been struggling for many years with issues around a disability or an illness, and lots of times trauma-induced issues, and they've had a lot of struggles in treatment systems, can be really hard to kind of think into the future. So we have to think about different ways to sort of ask some of these questions. So years ago, I remember, like, just as one example, our peer specialists here at Yale have taught us quite a bit about this. And we've done a lot of work in the vocational supported employment space. And there's often a question like, tell us about your vocational goals, right? And we do these vocational interest inventories, but that can be pretty intimidating. And our peer specialists started asking the question, I want you to think back, like before the first time that you went into the hospital, like when you were a kid, when you were a teenager, what did you dream of being when you grew up, and why? Like, what about that did you think was cool? And it just unlocked like all of these great ideas in the person and got them talking, okay? It's also true that goal setting takes time and a trusting relationship. And it's very much so true that when you're doing goal setting in partnership with someone, what you're going to get on the front end at an intake is very likely going to look quite different than what you're going to get 6 months or 6 years down the road after you've established that rapport and that trust, okay? So it unfolds developmentally over time. And sometimes, and somebody had put something like this into the chat, like sometimes a person, you're thinking bigger, but the person is really heavily focused on symptoms, on problems, on just kind of getting rid of the negative. They're having a hard time kind of vision setting, okay? Which, by the way, sometimes that's because of our treatment systems have been heavily focused on that, okay? So it takes a while, not just for practitioners to get out of habits, but also people that we support and serve internalize those things, okay? So I can think of people that I've supported over the years that they come in, they sit down, it's that time of year again, we're going to do your PCP. I really want to follow your lead here, and I want to focus on what's most important to you and what you want your life to kind of look like. Let's think ahead here a little bit together, and let's talk about that long-term goal. And I've had plenty of people, say to me, I'm going to take my meds, I'll come see you once a week, and if a voice tells me to hurt myself, I will go straight to the ER and check myself in. Are we done? And can we get coffee now? Okay. And that's the conversation around the long-term goal. But I don't believe that that is what that person fully wanted out of life. I believe that that was what he was sort of socialized into. And so it takes a while to help folks to have faith themselves and think big, right? So if somebody says to you, I just want the voices to be quiet, or I just want to be less depressed, or I just want to stop getting sent to the principal's office, that's where we have to step in as a partner. And we have to say, like, so if those things are better for you, how's life going to be different? Like, what are you going to be doing? Who are you going to be spending your time with? Maybe somebody says, well, I'll have friends at school, or maybe I'll get, back to church on a weekend, or whatever it might be. Okay. So I'm going to give you some examples of lots of tools that are out there around strengths-based inquiry and goal setting. I'll give those to you in a second. But the other thing to remember is that in the PCP model, we're focusing much more heavily on capitalizing on the invitation of natural supports into this process, right? At the discretion of the person. It could be family member, a neighbor, somebody from a spiritual community. So like, who else in a person's life can help? I mean, I can think of stories years past where somebody was really struggling and we were having a hard time coming up with a goal statement, and the person didn't use verbal language to communicate. So there was a whole bunch of barriers to the PCP goal setting. But a sister ultimately got into the loop and started coming to some of these conversations and let us know that they had been an ASL, an American Sign Language interpreter, before they started to struggle with some things with their health, okay? Which was like something that nobody on the team had ever discovered. But the sister shares this, and it didn't happen magically overnight, but ultimately it got built into the PCP plan and the process that they were going to be having this particular person offering some support to someone else who was in the program who was deaf. And they had, you know, again, a good relationship, but it gave that person a sense of purpose, kind of got them out of their shell a little bit, but we never would have known that and to build that into the plan if it hadn't come, you know, from that particular sister. And it's okay. Practitioners will very often say to me, I've done all those things, Janis. We've used your interview guide and we've asked all the family members, and they're still really stuck and they can't identify a long-term goal for the plan. And that happens again for a bunch of reasons. Sometimes people get very demoralized over time and it feels risky to kind of have hope and think big, right? But it's perfectly okay to use your own observations and make a suggestion and get the ball rolling. Because even if the person is having a hard time identifying their strengths or their interests or what they might like to do more of in their life, you're going to know that as a trusted supporter. And it's not putting words in a person's mouth to make a suggestion. We, again, I try to think of examples from my own work, and I do quite a bit of work in residential treatment settings. So group homes, adult care home type settings. And I can think of someone who had been living with an experience of serious mental illness for many, many years and had been in and out of the state hospital, quite isolated in their life. And at the time that I'm thinking of this story, they were really isolated in their bedroom at the group home, and you know, rarely would come out of the group home to interact with other residents, maybe once a week to get over to the mental health center. And I can remember the residential house director. Some of you work in residence will sympathize with this. There was a call out on a weekend and they unexpectedly had to go into the residence to cover a shift on a weekend. So that house manager went in on a weekend, and because it was last minute, they had to bring their dog, their personal dog, to the residence when they went in. So they bring the dog to the residence, and lo and behold, guess who's out of their room? Right? The person that they hadn't seen in a month. And suddenly the person's out and about all weekend. They're hanging out in the kitchen. They want to feed the dog. They want to walk the dog. They ask if they can brush the dog. And again, it just hadn't come to light that this person really had a connection to and really loved animals. So it unlocked a very different kind of a conversation around, I couldn't help but notice when I had to bring my dog last week that you just seem to love spending time with him. And like, have you ever thought about working with animals, or do you want to volunteer at the local shelter? And it was just, again, using powers of observation to make a suggestion. So you can be a partner in this is the bottom line of what I'm trying to sort of share here. Okay. Part of how you partner is by asking these different kinds of follow-up questions, just to dig a little deeper. Okay. So I won't go through all of these. You'll have them in the slides. But people will get focused on just staying out of the hospital, which is a good thing. We don't want people to live in institutionalized hospital-based settings. But if you're going to be out of the hospital, what would life look like for you? What do you want to be doing? Who do you want to be spending your time with? What would an ideal day look like for you? And then we can build the plan around some of those kinds of things, right? So I tried within the slides to think of some of like the most frequently asked questions that come up when we talk about goal setting. Because sometimes what I will hear is that all this PCP stuff is great, Janis, but I don't think you understand that the people we're supporting here, really how ill they are and how serious and persistent their experience of symptoms are, right? So first of all, bigger picture, I will just say, PCP is not a model that only applies to people who are, advanced in their recovery or kind of well on their way with their engagement. In fact, really should be a right for all people receiving services. It probably is even more important for people who are struggling the most, okay? So sometimes people ask the question, how can this person be in the driver's seat of their own care plan when they're experiencing active psychosis or unshared beliefs, whichever language you use? How can we be a partner with them and let them be in the driver's seat when they can't string coherent thoughts together, okay? So I want to acknowledge that how we do this needs to look different with each person or family that we're partnering with. But the truth is, if we can get alongside people and be willing to really explore and understand some of those beliefs, sometimes there's a lot of genuine meaning in there that we have to understand better before we can write a plan. I will be the first one to say, I mentioned I'm a clinical psychologist by training. So in a lot of ways, I got trained, how do you do a multi-axial DSM diagnosis? And how do you treat and extinguish symptoms, okay? But even though that's what a lot of times where our brains jump as a practitioner, sometimes that shortcuts really important conversations. And frankly, sometimes it shortcuts the fact that not everybody's goal is to get rid of symptoms. Some people learn how to manage them quite effectively. But let's just say, for example, here's another story. Let's just say this is another residential type of example. And so I was supporting a team who was supporting a man who was living in a group home. He had a very serious co-occurring disorder, experiencing psychosis, pretty heavy polysubstance use. And he was having a lot of problems at the group home because he had a fixed belief that he had been a Grammy-winning musician and sort of platinum winning, platinum record sales. And he had this belief that the people at the residence had been stealing his royalties checks. And so what would happen is he was getting caught in this cycle. He would get totally worked up about this. He would call the police would come on site. Inevitably, things would escalate. A lot of times he ended up in sort of a rehospitalization. It was hugely disruptive at the group home. And it needed to be addressed because it was so disruptive, not just for him, but for the people around him. But again, he has a family member who gets involved in this process through working with a peer support project. And we find out that, 25 years ago, this guy was like a super accomplished sax player. And he had played at some of the biggest, hottest clubs in New York City, right? Like pretty famous, like right off Broadway, like jazz clubs, okay? So even though he had developed this disruptive belief around the royalties being stolen, the truth is music was a huge part of his life. And they used that as a window of opportunity to open a conversation about how did he have an interest in reconnecting in that? So again, it didn't happen overnight and it was a multi-month process, but this is a man who went from calling the police every couple of months and lots of disturbances at the group home. He ended up volunteering in a local urban community center, and he ended up teaching music lessons to some of the kids in the after-school program, right? Which wasn't a magic bullet to fix everything. but it was in many ways transformational in giving his life purpose and helping him join with his team. And it only started because people were willing to actually talk to him about this thing we call psychosis and get a sense of what it means to him in his life. So it can still be fruitful ground. So I'm just trying to offer some examples of why we still do the exploration. Then when you're doing the exploration, here's just a snapshot of some of our favorite questions. I'll give you a resource on the next slide, again, referring back to the VHS toolkit, but I love the miracle question, that one in the top left, right? If you had a magic wand, you could be or do anything, what would you wish for, right? If you could design the perfect day, what would it look like and who would you be with, right? Or sometimes people have a hard time identifying their own strengths, but if you ask them, well, what would your best friend say that they love best about you, or your mom, or whoever it might be, or what's the best compliment you ever got, okay? So all sorts of examples of these kinds of strengths-based exploration tools, goal setting tools, vision planning tools. There are a multitude of them already available to you and cataloged and organized in that BHS PCP resource toolkit. Remember, that's the one that I said that's online. It's the toolkit that you can access after you've done the introductory training. And what we did was, there are tools, one snapshot, the bottom left there are some of the tools that me and my team that we've developed in the behavioral health space, charting the life course, and the Michael Small bottom right, person-centered thinking tools have been used widely across disability, including with people and families who are navigating intellectual disability. The top right is a snapshot that comes out of your PCP guidance document and your suggested planning template. So even the template that's being offered to you has some really nice embedded questions to make sure you're doing and soliciting some of those person-centered goals. So we made sure to put a very broad diversity of content of different types of tools into this toolkit. Some people like visually organized tools. Some people like lean and mean worksheets, okay? So just access and use the tools that work best for you and the person and family you're supporting, because there's a lot in here, okay? All right, let me shift gears here. I'm trying to be cognizant of time, and a lot of questions have already come into the chat about this. So, you know, I often hear, but I don't want to set a person up for failure. That goal is not really realistic, and we don't want to encourage it and then have the person, you know, experience failure. So I guess the first thing that I would say to you is that, you know, we don't have a crystal ball to predict the future, right? I mean, I'll be honest, I had a rough go of it back in high school. I got myself in a fair amount of trouble. And if you had asked my parents at the time that I was going to go off and finish college, get my doctorate, and end up teaching like this, you know, they might have thought that was pretty unrealistic at the time. But they stayed behind me in a difficult time. They kept supporting me, and eventually I found my way. So we don't have a crystal ball to see into the future. And more importantly, when you talk to people with lived experience, we do more damage with a legacy of low expectations than we do with helping people to think big, okay? So it's really important at the level of the long-term goal. Let the person think as big as they want. If it's motivating to them, if it's going to help them dig in and do the hard work to get there, then just go with it. You have opportunities elsewhere in the plan, most notably at the level of the short-term SMART objectives, to then break it down into things that might be bite-sized chunks that are more realistic, okay? So I'm going to pause here and I'm going to show a video. If you haven't heard Pat Deegan speak, Pat is probably I think, the single most beautiful speaker and advocate in the international recovery movement over the last couple of decades. Pat is also a person who talks openly about their long experience of psychosis and early hospitalizations. So I'm just going to share the first few minutes of this video before we move on and talk about how do we progress into the next part of the plan. So I think this really illustrates this quite powerfully. So here we go.
Very early into being in the hospital, literally within a day, I was diagnosed with schizophrenia, undifferentiated type, with paranoid features. And that became the diagnosis, and that diagnosis took on what I call a master status in terms of my identity. The fact that I was Pat, the fact that there were many aspects to who I was as a person became absolutely irrelevant once I held this label, this diagnosis. What mattered was that I was a quote-unquote schizophrenic. In other words, my humanity seemed to others to be quite secondary. So the fact that I had friends, the fact that I was a good athlete, none of this seemed to matter. It was like wearing a scarlet letter in big neon lights. This is a disease, not a person. This is a disorder, not a person. So he felt like he knew my future. He had read a generic textbook and simply applied it to the case in front of him. Schizophrenics don't recover, Pat Deegan won't recover. And it was that simple. And he urged me to go into a halfway house and to go on Social Security and to essentially retire from life. And then I remember having a thought, and I had never had this thought before, but the thought came to me, I'm going to become Dr. Deegan and change the mental health system so that no one ever gets hurt in it again. Wow, that thought had never come to me before. And yet, it held me with a power. It became for me what I call a survivor's mission. In my own understanding of it, I believe that I have been called by a power greater than myself to do the work that has become my life work. I do not tell that to psychiatrists or treatment teams when I meet them. Miss Deegan, if I had gone to the treatment team then, Miss Deegan, what is your goal for your treatment planning this year? Well, doctor, I have been called by God to change the mental health system so that no one ever gets hurt in it again. Delusions of grandeur. Up the haloperidol. So I kept this new dream, this new survivor's mission to myself. It became mine. It became something that around which I could organize my recovery. And I think that this is so important, that you can't organize a recovery around a vacuum. You can't organize recovery around nothingness. We need to organize our recovery around something that has meaning, something that has purpose, something that gives us a sense that I can begin to move. The driving belief.
All right, I'm gonna pause that video there. I don't think that requires much elaboration, but she speaks so powerfully to how important it is to organize the journey and to organize that person-centered plan around something that matters most to the person, okay? So to take a step back and to put on our practical nitty-gritty hats, another frequently asked question here comes up around, all this talk around, the strengths and the long-term goal statements. Where on earth in the plan do we tackle the problems and support our payment for services? So I'm just going to circle back to what I said at the intro, that it really is a widely held misperception that person-centered planning documentation is soft. You can write a plan that honors the person and it still satisfies the chart. There are lots of different ways that you can weave that golden thread of medical necessity. The content just may show up in different places that are not as familiar to you, okay? So I'm going to illustrate what that looks like. But I want to acknowledge that at this point, it's really critical to be thinking not just about your skills as a PCP plan facilitator and plan writer. This really requires systemic alignment between the people who are delivering services, the people who are leading services, and the people who are funding services. And I just want to acknowledge that there have been efforts in North Carolina to specifically work with your tailored plans. We offered a customized introductory training in year 1 of the initiative. I just did a follow-up webinar for a TP specific audience. And in this next phase of the initiative, there's going to be a statewide learning collaborative that some of you may be interested in participating in. And the tailored plans are going to be involved in that. So again, if you're interested in hearing more about that, I would contact your tailored plan around it. But I just want to acknowledge that this is a place where we have to think both at the micro level and the macro level to get quality implementation. So what we're really talking about here is juggling these tensions in the plan. On the left-hand side of the list, everybody's chasing us around regulations, medical necessity, compliance. But then in the PCP world, we're talking about collaboration and person-centered and strengths-based. And how do these things come together in the person-centered plan? So let me just give you a big picture illustration before we end on kind of the short-term goals statement. And I'll try to leave a few minutes for questions. In a traditional treatment planning documentation model, what we do looks like the left. It's very problem-centered. One goal for every problem in the assessment, right? So there's assaultive behavior, there's poor hygiene or ADLs, there's substance use, there's auditory hallucinations. What's your goal for your poor hygiene? What's your goal for your assaultive behavior, right? You can see pretty quickly how that becomes a completely deficit-oriented pathologizing plan that a person's going to have a very hard time connecting to, okay? On the right-hand side, you take that same kind of story and think about it through the lens of the person. How are those things maybe getting in the way of their life and what's important to them? Maybe they want to get their job back so they can be a good provider. And yeah, maybe at their last couple of jobs, they got fired because they lost their cool, right? And then they got terminated. Or maybe they're really struggling in job interviews as they're looking for a job because they're severely depressed or having a hard time attending to putting their best foot forward with their hygiene. Or maybe substance use has led to chronic absenteeism. So you can integrate these things in one good quality plan, but it's critical that that long-term goal statement be something that resonates with the person, that matters to them in a quote about their quality of life. You have opportunities lower in the plan, most notably at the level of the short-term objectives, to break them down and target the barriers associated with illness or disability or health condition, okay? So the important two is most often reflected in that long-term vision or goal statement. Those were all the things, the 3 things that you put in that chat box in our opening exercise. Whereas some of the things that might need attention, that might be important for the person to attend to in the PCP process, health and safety issues, disruption or functional impairments from symptoms, managing risks, those are best targeted in the PCP barriers and in the short-term objectives. So let me say a few words about what that transition likes and offer you a couple of quality tips around the short-term goals. So in that transition, you're basically saying, we've taken the time to get to know what matters most to you. We've got a really nice person-centered long-term goal. But now, what are the barriers that are getting in your way? What could you tackle first? Okay, let's pick something out of that list. And then what's going to be the proof that that thing is getting better concretely in a measurable way, you know, in a way that matters to the person and moves them along the trail. Okay, so short-term goals, those are your concrete, positive changes in functioning, changes in behavior, status. What can the person do differently? What can they enjoy? What new activities in their daily routine? It takes the bigger chunk long-term goal and divides it into these more manageable bite-sized pieces, okay? So in that sense, they send a hopeful message that even if the long-term goal statement is a long ways down the road, maybe it's going to take years to achieve it, but it sends a hopeful message that we think some things can and will be different for the better in a concrete way in a pretty short amount of time. So let me give you a few examples of that. So let's take someone, we'll call her Barbara, and Barbara knows that getting out in the community is important. A big part of her recovery someday, her long-term vision, she wants to have a job working with animals. She's a big animal lover. But also right now, Barbara's wearing tinfoil on her head because she has an idea that people are able to read her thoughts, and she's trying to block other people from reading her thoughts. And so she's wearing this tinfoil on her head. She's embarrassed to leave the house and go out, right? But going outside without it causes her a lot of distress, okay? So she's just not going to the dog park. She hasn't left the house in 3 weeks. She's not coming to services. So in a very traditional treatment plan, it would default to this model on the left. Paranoid delusions, lack of insight, poor compliance, increased reality testing. Achieve and maintain clinical stability. But on the right-hand side, we can really think about that through a much more person-centered perspective, okay? So someday, the long-term goal Barbara wants to work on is she wants to work in the community with animals. And yes, she's having some things that are causing her considerable distress, including feeling exposed and unsafe, difficulty leaving the house, disconnected from outside supports. And then the short-term goal or objective can be focused on within a couple of months, she's going to feel safe enough to resume her visits to the dog park at least one time per week. Okay, so it's not disregarding some of the issues that are coming up around her experience of an illness or a health condition, but it's thinking about it through a very different lens. And it actually ended up leading to some pretty creative, very simple solutions. There were lots of conversations around therapies and different medications that might help. But then we even started about simple things like wearing a hat, right? Sometimes we just, let's go with the simple strategies. Wear a hat when you go to the dog park. All right, so some of you are, many of you are hopefully familiar with this little strategy here. When you write your short-term objective, also known as your short-term goal, this is where you want to hit your SMART criteria. So you have an obligation in your treatment plan documentation to hit this measurability, but we suggest, and in the PCP guidance document, you can do this at the level of the short-term goal so that long-term goal can remain free to be authentic and come from the person as a quote. And people don't live their lives and speak in terms of SMART long-term goals, right? But at the level of the short-term goal, we can do that. So simple or specific, measurable, concrete, did it happen or did it not? And if there's any difference of opinion, then it was too loosey-goosey. You got to tighten it up. Does it have a time frame or a target date? And is it relevant for that particular individual? Okay. So some people have said realistic, but I think that overlaps a lot with achievable. So increasingly the field is saying the R stands for relevant. So what you're essentially saying there is make sure that you're targeting progress in a barrier that's actually interfering with a person's life. Because sometimes something may look a little off in an assessment, but it's really not distressing to the person or causing them any difficulties. So if you take hygiene as an example, that's come up as a few times. If a person's long-term goal is that they want to work in customer service in the community and they're going on job interviews, then by all means, it would be a relevant barrier to target in that short-term goal. However, I often say if you're a stay-at-home grandma living in a multi-generational household and you're watching your toddler age grandkids, right, for your daughter, those grandkids do not care if you shower a minimum of 3 times a week over the next 90 days. It's not as relevant to her goal of being a good grandma and taking care of the kids. You might have short-term goals there around demonstrating the ability to safely cook macaroni and cheese on the stove without fire hazard, or safely using emergency response if there's some kind of an emergency, or getting them from the bus stop, okay? So those are SMART criteria. If you're struggling to meet your SMART criteria in your short-term goals, I often coach people to use this rhythm here, within what amount of time is the person going to have improvement in which documented barrier. There's your connection back to your assessment, which is critical in the rigor of your documentation and in creating a focused treatment plan, as evidenced by what meaningful change in behavioral functioning, something they can do differently. And I've offered you a few examples there. Somebody who wants to keep their job, they're really struggling with severe panic disorder, taking the subway, chronically late or missing work because they're getting off the subway, having panic attacks. So maybe within 30 days, John's going to have improved management of panic as evidenced by taking the subway to work without exiting the train before the stop. And you negotiate these in partnership with the person based on where they're starting and what feels like the best first step. And then my last tip on the short-term goals before I close with an example, the biggest quality tip I can give you when you transition to the short-term goal, short-term objective, is you really don't want your short-term goals, your objectives, you do not want them to be about service participation. Sometimes I see plan facilitators, teams do a beautiful job connecting with the person, partnering. They get a beautiful long-term person-centered goal statement. But then I drop down to the level of the short-term goal and everything says, attend therapy, attend the job coach, see the psychiatrist, attend. That is not the short-term goal. You have to ask yourself, if the person is taking advantage of all those services and supports that you're offering, what are they going to get out of it? What do they hope is going to be the concrete desired result, right? How is their life going to be better? That's the question you got to ask at the level of the short-term goal. So to give you an example, I remember working with someone who was a trauma survivor who had been married for many years. And because of emotional dysregulation, this woman was using a lot of self-injury to manage that, cutting in particular. And at one point, she and her husband became estranged. He was still on the scene and they were working to reconcile, but he had gotten very burned out. So the team did a really nice job at the level of the big long-term goal and understanding that Wanda's long-term goal was, I want to work on my relationship and repair my relationship with my husband. But when you go to the short-term goal is not attend CBT twice weekly or attend trauma therapy. Those things are the services or the interventions. You have to ask, if Wanda goes to that trauma-informed treatment, what is concretely going to be better in her life as a result, right? What's going to be the desired outcome? Well, maybe Wanda's going to apply some different mindfulness techniques to decrease or maybe even completely eliminate, right? Or decrease instances of self-injury to no more than 1 per week within 90 days. Concrete, measurable reduction in that behavior through the development of additional skills. So you see, here's how your SMART criteria are playing out. Here's how your measurability is playing out. Your link back to your assessment, the ongoing building of your golden thread of medical necessity. You can do all of that and still keep the long-term goal focused on repairing the relationship with their husband. All right, final example, and I'm going to open a poll. We're just going to do the first part of Jerry's plan, and I'm going to have you vote on what you think his long-term goals should be based on what we've been talking about. So Jerry is someone probably 25 years ago in my career, but he actually taught me a lot about person-centered care and planning. He was a 42-year-old white man. He was living with a diagnosis of disorganized schizophrenia. He'd been in and out of the state hospital for very long periods of time. When he was out in the community, he was often living in a group home with 24-hour supports. He had a lot of strengths. He was well-liked by his peers. He was a very funny guy. He had a supportive brother on the scene. He could tell you what he liked to do. He loved music, Chinese restaurants, Chinese food. But, he hadn't been feeling well enough to enjoy those things. And at the time I remember, he was someone who was pretty much staying at the group home 7 days a week, really confused, pretty fearful of others. When he was feeling well, he would go to downtown jazz festivals, things like that, meet people. But at the time in point, he really wasn't getting out of the house at all, other than to come see me once a week. He didn't know if it was maybe side effect of medications, that kind of zombie-like feeling, or maybe it was his experience of symptoms of the illness. But more than anything, he wanted to get out and have a social life again. It had been 10 years since he had dated anybody. He really wanted to have a girlfriend, but he was afraid and he didn't know where to start, okay? And he also had a hard time even just being able to take the bus, and he was afraid to go anywhere alone because sometimes he would get confused, he'd get off at the wrong stop, he'd get disorganized. He could only tell people when he was under stress. Somebody would ask him, "Can we help you, sir? Where can we take you?" He would say, "Take me to the hospital." So that would then trigger this whole evaluation, sometimes rehospitalization. So he was really struggling with community mobility, and he didn't know where to start. And he just wanted to get social again, and had a partner, 10 years, okay? So Ingrid's gonna open a closing poll for us. And based on what we've talked about, I want you to pick what would be the most powerful long-term goal to organize Jerry's PCP around. Oh, Ingrid, hold on, Ingrid. Stop the horses here. We opened the short-term goal poll. Can you just double check? We're gonna open and vote on the long-term goal statement. Sorry about that, folks. We have a bunch of the polls in the background. You want me to do it?
Sorry about that. Let me
No
retry.
worries. There you go. Thank you, Ingrid. All right. Okay, Ingrid, why don't you go ahead and close it, and we'll talk through the options. You can share the results there. Thank you, folks, for being good sports and doing that as we sorted it out. All right, so we've got quite a mixed bag here, okay? So remember, we're talking about the long-term person-centered goal, kind of big picture, forward-thinking, quality of life, not about symptoms. I would actually say for those of you that chose the golden one, I want a girlfriend, that was consistently the most important thing of what mattered most to him. He really wanted to date again, okay? So we had some responses around each of the others. I just want to be happy. That one is a little tricky. And actually a question before the webinar came in about this because it's an I statement, it's a quote, it's forward thinking in his own words, but it's a little bit too vague. And if somebody just says, "I just want to be happy," or "I just want to be normal," you got to ask the question, well, what's going to make you happier? What do you think? What does it mean for you to be normal? Like for someone that might mean, "I want to get a job," but for Jerry, it meant, "I want to get a girlfriend. I want to date again. I'm a healthy 42-year-old guy here," okay? The attending social skills group in blue, that's not a long-term goal. Remember, attending services is just that. It's a service or intervention. We want to keep that long-term goal focused on the North Star. Managing the distressing symptoms of paranoia. Jerry would actually use that word, and that was incorporated within his plan, but we would tend to tackle that at the level of the short-term goal or objective, right? So feeling less fearful of others, as evidenced by being able to ride the bus, for example. And then the top one is a quote. But remember, with the long-term goal statement, you want it to be something they're moving toward, not just something they're getting rid of. So if you were to say to Jerry, so if you didn't feel like a zombie, how would your life be different? He'd tell you he'd be dating on the weekends. So everything leads you back to the I want a girlfriend. So just for the sake of time, what I'm going to do is skip over our next two polls, because this webinar really isn't focused on the entire plan as much as it is the critical nature of that long-term goal statement. But I'm going to end by showing you the example of how it might come together, because many of you asked those questions. So just know you can organize the PCP around this long-term goal. He had a lot of strengths to draw upon, but he also had a lot of barriers, assessed needs, difficulties associated with his experience of illness that were getting in the way. The bottom, you see, and this will all be in your slides. You'll have a copy when you get it to take a closer look. But maybe he's going to start by getting out of the house in one chosen social activity each week over the next 90 days. Then we wrap a set of services as well as natural supports around him to help him do that. We know who's doing what by when and for what reason, whether that's cognitive behavioral therapy, medication management, travel training. We get the brother involved and we get Jerry involved. Okay, so you'll have this to look through, but hopefully by at least giving you a quick tour of that, you're getting a better sense of how we really can organize a good quality plan around a quality long-term goal statement, and you can still continue to satisfy your pressures in your documentation. Okay, this is central in our partnership with people and families, so we can help them move forward in their lives. Okay. So you will see on the screen here, and I'm going to check chat to see if we had any questions come in. There is a QR code to our post-training survey, which you must complete either now, only takes like 2 minutes, not even, or within 2 weeks at the latest. Okay. Ingrid is also, if you're not a QR code person with your phone, Ingrid's also going to put a link to the post-training survey in the chat box, and you'll also get it as a follow-up by email. So I will, again, leave this up here on the screen. It's in the chat. I'm going to go ahead and quick check the chat for questions. Thank you all for your participation in the polls and in the chat box exercises. I hope you found it helpful. Please check out the resources that we embedded in today's training. And let me see, I have a minute left here if I can find anything. The speaker, so Courtney, I'm Janis Tondora. Ingrid can throw that in the chat for you. I'm very accessible by email. Okay. Marty's pointing out really the important role of stretch goals, thinking big, taking that dignity of risk, right? We don't have to minimize health issues or problems that are getting in the way. We're integrating those at the level of the barriers, the short-term objectives, the interventions. Okay. All right. Okay, so some thank yous are coming in. I want to be respectful of everyone's time. Please do the survey. Check out our resources we've offered, and keep your eyes peeled for follow-up communications by email. All right. Thank you, everyone. I hope you found it helpful today and look forward to hopefully seeing you in future PCP events. Take care, all.